A lot of what I will be talking about is personal experience and team experience rather than data-driven. As was mentioned by one of the speakers earlier today, we're in a frontier of defining this space largely. So we're going to work together now, and each time we come together for these meetings, I'm sure the data will be further evolving and we'll have more data to base our talks on, where right now we're living and building that data. So these are my disclosures. So I'll be talking in terms of three main objectives: identifying the lack of data on the topic and conformity in practice patterns, and that would be in terms of clinical or data-driven follow-up post-ablative therapies. I'll present to you my personal perspective and the clinical workflow that I've implemented with some of the rationale behind why I've chosen to do what I'm doing, understanding that even that is going to morph as we move forward. And I'm going to hopefully promote some thought and discussion within this group with the goals where we can work together to develop best practice statements moving ahead. So what are we lacking as a field in this focal therapy space for prostate cancer management? So I would love to see the NCCN give us surveillance following focal ablation. Largely at my institution, as one of the NCCN members, we like to follow NCCN guidelines for most of our management, but really that subheading that you see there is something I typed in. It's something I want to see in next iterations. There's huge variability in the follow-up post-focal prostate cancer ablation. PSAs, are they done every 3 months, 6 months? Are there other intervals that individuals in the crowd are using? We know that imaging is largely the basis for us selecting our patients for focal therapies for prostate cancer. But then do we follow with those same imaging modalities? Are they MR, which brings most of our patients to focal therapy? Are we doing that post-treatment? Are we doing a baseline at 6 months? Is that long enough for all the modalities we use to sort of settle out? Are we doing it at 12 months? Or are we doing it only as a PSA triggers some concern? PET imaging. We had a whole session this morning of thoughtful sort of comments and learning from the thought leaders, many of the individuals that have worked in the space of PET tracers for prostate cancer. And what is the role of using these in a serial manner, looking for intraprostatic assessment post-focal therapy? And then biopsy. This has been commented on just prior to the break session we had, and biopsies are certainly done after focal therapy. We know that, but when, how often, and how many times? So looking into the literature, looking into the data we have available, this is a multidisciplinary consensus statement from an international cohort of experts, some of whom are here. And this is to provide standardized nomenclature, but also surveillance methodologies exactly in the space that I was tasked to speak about. But I'll talk to you about how we've adopted that nomenclature and surveillance recommendation from the consensus and how we've morphed it at my institution. So how do I do post-focal therapy follow-up, and what's that rationale? What's the basis for it? I think it's a morphing and changing practice over time, and a large element of that is based on experience that's been gathered with recurrent cases and with successful treatments, both alike. So frequent PSAs is how I started, annual MRIs, how I started, and serial post-ablation biopsies. These men were all on a strict active surveillance protocol after their focal therapy when I started the program. This was early in our programmatic experience, about 10 years ago, and it was based on the consensus statement that has come out in that interval while I've been doing this. But with that experience of defining which patients had recurrences and which patients were being subjected to recurrent blood work, advanced imaging, and those undesirable biopsies from a patient perspective, we recognized we can better define which patients are going to need the full gamut of workup at various time points versus which ones we could defer. And so we found the negative predictive value very valuable and very guiding of whom we could defer biopsies. And we'll talk about how, based on that, and based on the definition of the imaging post-ablation, the targeted biopsy pathology that I did on a stringent annual basis, how we've now decreased the frequency of doing these studies. So as with anything, there's an evolution of techniques, and these environmental pressures have driven change over time. That came with my and our institution's experience, but also came with the pressure of our patients not wanting biopsies time and again when we had successful ablation and negative pathology year after year in their follow-ups. So it honestly comes to a value proposition, and this is what I put forth to each patient when we discuss post-HIFU or cryo or IRE, the modalities that I offer at our institution. What are we looking for after their focal therapy? We should be looking for patients that have localized cancer of a significant degree that will be a threat to their quality or to be a threat to their longevity of life. And so we have to balance the morbidity of putting them through serial biopsies versus the clinically significant findings that may render a treatment pathway that can come from that post-ablative biopsy that we do. And so finding our way, as Mark Twain said, two roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. So again, in a thought-provoking way, I would pose really personalizing the experience for each patient after their ablative therapy. The patient that went into it with higher grade cancer, a higher burden of cancer, the patient whose volume of disease was such that we were hesitant whether or not our coverage with our treatment modality would have been ablative and successful, maybe on a different pathway, but we also have to factor in what the patient requests. So our typical workflow now is a PSA at 3 months and 6 months. I actually now, with added experience, pose whether or not people who are doing their various focal ablative therapies are doing that 3-month PSA. Does it give us a baseline, or do we still have residual inflammatory change that gives us a falsely elevated 3-month PSA, which is certainly what I see as I still do it. I really am banking on the 6-month or 12-month PSA after treatment. As you see bullet number 2, that PSA does come up at 12 months, at which point I do an MRI. Many patients who I've done MRI at 6 months based on that consensus statement have actually found diagnostic difficulties, as was mentioned by our MR session presenters earlier this morning. Biopsies at 1 year. I know many in the room have mentioned that they do biopsies at 6 months. I think modality to modality, it makes a difference. I also think the anxiety-provoking nature of the results is a big deal for patients. So if they have positivity and they have just recovered from their treatment and it's only 6 months later, will that provoke a discussion to then go whack-a-mole what's recurrent or persistent, I should say, at that point, versus do we lose any ground by waiting that full year? And then really the change, rather than doing annual biopsies as a dogma that I followed initially, I really then used that 1-year biopsy as a pivot point. So if the pathology at that 1-year follow-up biopsy is benign, then we do imaging and serum biomarkers, PSA and MR, sometimes PET, but we then do not impose another biopsy thereafter unless there's cause. For patients that have cancer found on their 1-year post-ablative biopsy, then we decide on a case-by-case basis, are they best suited for surveillance or treatment? So I'm going to focus on exactly those patients. So a patient has had ablation, their PSA follow-ups, their MRI or PET imaging, and it's their 1-year subsequent biopsy. And we find cancer on that biopsy. So at this point, I'm resetting the case altogether with that patient. We have to reevaluate them as a new scenario. Is the biopsy recurrence or persistence found in field, which is the area that I had previously treated, or is it in the completely untouched prostate area that has not seen thermal, electroporative, or other energy modalities to disrupt the tissue? What is the grade of that cancer that's found a year post? What is the stage on imaging? And what is the volumetric burden? A lot of the stuff that came up in our discussion from the biopsy pathology definitions just prior to the break. And then we have to also look back. What is their history? What was the dynamic change from the cancer that was treated a year prior? What was the volume of that original cancer? Did we cover it all? What was the margination, which we heard about is evolving as we integrate AI. Obviously, the margination that we determine may not know exactly the extent of disease at our first treatments. Hopefully, it will in the future. What modality of treatment was used, which of the energies that we learned, there's a vast majority of consistent killing of cancer. However, there are differences. There are reach differences in terms of getting the energy to the right spot. And then the access. From what area, from what modality was that energy implemented a year prior? Because that may change the safety and efficacy of subsequent treatments. And then at that finding of prostate cancer on that surveillance biopsy a year later, what are we going to do? Are we going to treat or are we going to monitor? Also, if it's 1 year later or a for-cause biopsy sometime even after a year post-ablation, we have to choose always the safe, effective, and goal-oriented next steps for that given individual. So what can those next steps be? The prostate cancer treatments, we can obviously always go back and do various forms of ablation. We can do radical therapies of various sorts, whether surgical or radiation-based energies. We can repeat various forms of energy either to the same area, other areas, or encompass larger areas of the prostate gland as needed. But do we always use one unified pathway, regardless of what the treatment was? That's another question that I think we don't have the definitive answer to. There's obviously different treatment technologies we use, and they all have the identical goal of killing cancer, but the time to achieving that goal may be variable based on the energy implemented. The imaging that we get post-therapy with different energies and modalities may be quite variable. And then is PET versus MR imaging better for the evaluation, or should we use both? And we know there's differences post-thermal versus post-radiation, time points and how these different modalities show up. And we have to know the pitfalls. So primarily we focus on the cases where we have false positives. Right? But one of the things that's most important in my mind are the false negatives. Those are the patients that may get hurt if we are missing their clinically significant prostate cancers in our follow-up of their care post-ablation. And we have to consider the timing. Not all the ablations show up the same on different imaging modalities, but not all of them show up the same at different time points post implementing that ablation. So I charge this community, I charge us to help define these better. Our goal ultimately is to decrease morbidity, and obviously oncologic sound care needs to be maintained, so decreasing prostate cancer specific mortality. But in this patient population, we are more primarily focused on morbidity because if well selected, mortality should not be an appreciable number that we should have opportunity to change. It should already be ultra, ultra low. We want to detect prostate cancers thereafter with a for-cause workup. This would be PSA triggering imaging, only imaging of concern going to biopsies. And another point, as I mentioned, a lot of these patients may be aging as we continue to follow them. We have to be very cognizant of implementing the appropriate selection between surveillance versus watchful waiting. So considering even post-therapy, what are the patient's life expectancy? Based on age, other medical comorbidities or priorities that may come up in the years after their prostate cancer focal. We have to know their original prostate cancer risk. What was the grade, the stage, the tumor volume and burden at the time we gave their original therapy? Have we gotten ahead of that dominant lesion, which was their true risk for metastatic disease? And if so, does additional therapy have any play in terms of their long-term, lifelong benefit? And then post-ablation data, I think this is very valuable. We need to know, is it persistence and recurrence versus those with a full treatment response? And depending on these men who are, again, aging and having other medical priorities coming up, I think as a community treating prostate cancer, whether in the focal space or whole gland space, we underutilize thoughtful, watchful waiting in many men who are becoming more aged and have other medical priorities. So this, again, imparts fewer tests than active surveillance. Patients love that if they can keep safe against their cancer. It's ideal for those older men who are more ill. And again, 70 to 80% we know have prostate cancer that is probably not going to impact their longevity. So in a lot of patients that I've now followed 5, 6, almost 10 years out from their focal therapies, watchful waiting after we discuss it in detail actually wins, even when they have low volume intermediate risk disease on follow-up biopsies. So I will end with this. Many of you may have already seen this in my talks or other talks. It's notable for this group of people in this society. Dating back several years, I think this is dated 1937, Hugh Hampton Young wrote, "We have shown that in the early cases of hemiprostatectomy, that may actually be radical enough. The removal of half of the prostate at that point was said to be adequate if that was where the carcinoma lay. And as long as it was within the capsule and not in the seminal vesicles, which comes back to some of our imaging talks from earlier today, if we define that the cancer is co-localized within the capsule of the prostate, this may be adequate and sufficient." So history does repeat itself. So I present this and thank you.